Okay. Ladies and gentlemen, let's get started again for this second session. Again, a warm welcome from my side as well, and thank you all for being with us today here. As we have seen from the launch of the action guide, we are going to follow all the steps of the cancer care pathway, and we will start now with learnings on prevention and screening, okay? The focus and the nature of All.Can is on implementation, and that's also another important reason why the case studies, the experiences that will be shared today have got to do with specific programs in which All.Can also is involved. We have the pleasure and the honor of having another stellar panel here of very distinguished experts. And I will not introduce them one by one, but I will just let the flow of the discussion go. And the objectives of this session start by illustrating how we can contribute to move the needle towards efficiency gains in prevention and screening, thanks to a number of partnerships, as I was anticipating, with organizations or consortia that are focusing, amongst other things, on prevention and screening of cancer care. There will be specific topics that will emerge in this discussion and that will be addressed in this discussion. One, for instance, is behavioral barriers in cancer prevention and how these barriers can be overcome through community engagement. We will address also the role of healthcare providers in supporting primary and secondary prevention thanks to patient education, screening, and referrals. The good practice examples, which are often part of our discussions and are also parameters of reference that can be used across countries, will be part of the discussion and will help identifying key factors that contribute to their successful implementation. And last but not least, I would like also to make sure that everyone tries to connect always back with the action guide. The action guide that was launched only a few minutes ago represents a framework within which several activities, including those that have got to do with prevention and screening, can be integrated, can be intertwined. So let's not lose sight of how the framework, or vice versa, how the actions that will be illustrated now can connect with the framework. And without further ado, now I will sit down, shut up, and let Marius kick off the discussion on prevention, and in particular on the project which is known as 4P-CAN. It's got to do with primary prevention, so you will be the best person to briefly also introduce 4P-CAN. It's a project which is funded by the European Union and which focuses on primary prevention. Marius.
Thank you so much, Eduardo, for the introduction. I'm Marius Gianta. I'm a medical doctor by background. I studied public health and I'm in the field of cancer policy and innovation for many, many years. Indeed, Center for Innovation in Medicine, the not-for-profit organization I actually founded 10 years ago, is coordinating the 4P-CAN project. But here with us are other members in the consortium, and I will start with you actually, Eduardo. But as well Ivo from BJCN and Cornel from ENSP, big organization, very relevant at European level, are here. And Bettina Borish is in the external advisory board. So we are very well represented here in this meeting. 4P-CAN is one of the projects part of the Cancer Mission Cluster on Prevention, and the project is focusing on building new models of implementation for the European Code Against Cancer, and in this way trying to reduce the East-West inequalities. We are 18 partners in the project, from 11 countries, 5 countries from Eastern Europe. So this is, I think, very, very relevant. And I mentioned that the project is around European Code Against Cancer, and the topic of our today meeting is around efficacy. And we all know what is the level of recognition for the European Code Against Cancer in general, and for some of the recommendations is very, very low, despite the fact that the European Code Against Cancer will have the 5th edition that will be launched next year. And one of the objectives in our project is actually, when the 5th edition of the code will be out, to be able to find with a new implementation model. And the big opportunity for us is the Cancer Mission, who actually allow us to build a bottom-up model in addition to the top-down implementation model. And this is something we are as well discussing in the ECOS project, establishing the National Cancer Mission Hubs, networks, and synergies. And EBA is part of the ECOS consortium as well, and Ivana is in the external advisory board. So many synergies. In building this, so our first question was, okay, for more than 35 years, a lot of people and organizations started or tried to implement the European Code Against Cancer in different environments, and we all know the results. And we said, okay, in this project we should start in a different way. And I mentioned the Cancer Mission as a big opportunity, because Cancer Mission is coming with some powerful tools, and we choose in our project the Living Lab as a tool to go at the community level. And in our project, we started to implement 2 Living Labs, one in Romania and the other one in Bulgaria. And in the Living Lab, you all know that the Living Lab has actually 3 phases. It's the idea, the prototype, the implementation. Then you learn and you adapt your idea, the prototype, and the implementation. So basically it's easy, right? But it's not so easy if you go to a rural area. And this is what actually we did 1 year ago, in September last year. So we went to a village, 4,500 inhabitants in the center of Romania. And we said, okay, we should start somehow. And then we had an initial assessment, and we identified 2 entry points in the community. One based on local authorities, and the second one based on regular citizens. And the first step in our approach was to use advanced social sciences tools in order to understand what is actually happening in this community. And Michael, you mentioned the big C, and this was one of the first findings, a very high level of fatalism and stigma at community level. So people tend to protect the cancer patients in the community and not to expose them to our scientific research or for citizen engagement activities. So with this in mind, and we perform personal and social network analysis, just for you to have an idea, we going with this type of social sciences tools, we involve 80 people from the community, and we are able to have very granular data from 60% of the people living in the village. So I think it's so powerful from a statistical perspective. So first of all, we understood that cancer is a word that people are afraid of. So the challenge for us was when we went in the community and we said, okay, we should have our first town hall with the citizens about the European Code Against Cancer. So how to go in a community with a very high level of fatalism and to speak about European Code Against Cancer. So we tried to use to find a new way to communicate. And this is actually related to the model of personalized communication that we put forward in the context of the pandemic. In other words, to tailor the messages according to the data that are coming from social sciences analysis. And we built the first event around the idea of how to best use research and innovation and implementation science, how to best engage citizen and community in order to make a change when it comes to cancer. So this was the first narrative in our project. And then actually we used the same approach. Then we, because this fatalism was still very, very high, when we actually discussed about the European Code Against Cancer, initially we called it the Code for Life, trying to focus on the positive aspects of this. And in this discussion during the town halls, we actually ask the citizens to choose what are their priorities from the 12 recommendations of the European Code Against Cancer. And this was very interesting because we identified the area of immediate interest for them: nutrition, obesity, and sedentarism. And we built the next event around the three the most of interest for them topics. So in this way, we actually build the trust between our team, the local authorities, and the citizen. And of course, this was the way actually to adapt our activities, and this is something allowed by the cancer mission frameworks and is allowed by the Living Lab approaches. A very interesting was during our first town hall with the citizens. At the end of the meeting, I asked the citizen who would like to volunteer to join the citizen jury. And we're like more than 10 hands up. I say, whoa, this is great, but you didn't ask me what is a citizen jury? What are your potential duties there? And they said, it's not important. We would like to be part of this. So we are working actually on a monthly basis with the citizen jury, trying to build the messages, the activities. We organized the Festival of Health in June, a big intervention at the community level. And I have one final remark. It's so important if we discuss about cancer primary prevention or screening program, not to look in isolation, but to look actually as a whole. Because we identified that people who have poor experiences with the health system, like a very low access to healthcare, to doctors. Maybe some of them should pay out of the pocket. And anyway, negative interactions with the health system, they are not so interested actually to be part of the primary prevention programs and screening programs. So before trying to optimize and to make more efficient primary and secondary prevention, I think we should look to what is actually happened to the healthcare sector level in order to understand what is happening there, what can be improved, and in order for the people to perceive this improvement, and because this will immediately translate to a higher favorability for primary and secondary prevention as well. I'll stop here, and thank you once again, Eduardo.
Thank you, Marius. On the one hand, thank you very much for your commitment and your focus really on making things happen on the field. That's so important when we talk about implementation, etc. I had almost forgotten to say that out of each of these sessions, of these panels, we'll try to extract some actionable items, calls to action, so that at the end of the day we have a list of actionable items per subject that, that we can carry forward as an organization, as a community, and so on. And so, Marius, think about your call to action, which I suspect may have got to do with the use of social sciences tools, for instance. Another thing that Marius mentioned is the European Code Against Cancer, and therefore I am very pleased and honored to have Isabel with us, who represents IARC. And clearly that was one of the important tools that IARC developed and implemented already since many, many years. That said, it's not about the Code Against Cancer that perhaps you may want to share your thoughts, but it's also about the data collection efforts that IARC is doing and how they connect with prevention and screening. Thank you.
So good morning, everyone. My name is Isabel Suryo-Mataram. It's a really difficult name. But so I am leading the work in IARC. So this is the International Agency for Research on Cancer. It is a specialized institution of WHO that works then on cancer research. We collect data from all around the world on cancer data, so cancer incidence, cancer mortality, survival, etc. And we put them into kind of a global observatory where people then can get then this data. We also then work on the European Code Against Cancer that is then mentioned here, which is then a recommendation or actions that people can take to reduce their burden. And then in terms of this code, what IARC has been working on is then adapting or tailoring this code to other parts of the world. So one of the newest one is then for Latin America. That was then published last year, really then looking into then, for example, context, behavioral, environmental factors in each region. At the moment, the code is being then updated for the European section, but we are intending then to increase then that coverage to other parts of the world. But coming back into all this, and then I see it also a lot in this action book, is about data. We talked a lot about data, and then often we undermine the availability of data. It seems like data is just available there, but that's actually not the case. But then before going there, I would like really then to show how important it is then to have data, because really simple data can say thousands words. That's what people say, right? So now I'm thinking whether I have to, you're clicking forward. So I was looking at the data, and this is just really simple data on cancer mortality, so death rates in Denmark. It took me really long not to choose the cancer sites, etc., but to choose actually the country. I wanted to avoid Sweden, because I know there's someone in Sweden in the panel. And then I was glad I avoided Australia, because there's a lot of Australians. So then I chose Denmark. And this is then the data on lung cancer mortality. It's very easy. Everybody here can see it then really rapidly, that lung cancer, this is for men, has been decreasing in Denmark. It went up around the 80s, but it went down. So there's something that the government, people, stakeholders that they did really well to achieve this. And then for lung cancer, it's really important. It's one of the cancer with the poorest survival, poorest prognosis, and it's the biggest cancer killer at the moment in the world, and also the most diagnosed cancer. So there are successes there. And then I think the fact that there is successes there, we should bring it as a message for it. We can do this. We can do this with lung cancer. It's a really complicated cancer. We should be able to do it with other cancer sites as well. And then this is the same data. It changed a little bit, still the same country, Denmark. But then you see then for female, it is then going up and it's going up later and then it's stabilizing for a while and it's going down much, 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 much later than what you see for men. So knowing the social context, as Marius has been speaking about, is really important as well. We managed to decrease this for men. And then in some countries like Sweden, actually females' lung cancer at the moment is higher than what you see in men. And then you're seeing it in many other countries where that cross, men is going down, but women is still then going up. And then next to the next country, so I was hoping that there's no one in from Portugal here. There's a lot from Portugal. I saw already the last names. There's Portuguese name here. So this is the data from Portugal. So that's the red one. The green one is then the data from Denmark, the same as what you saw before. In Portugal, I mean, it's 2 hours flights from Denmark. There's direct flights from Denmark to Portugal. But then you see for men, there's not yet that decrease that you see in Denmark. And that is 30 years behind than what you see then in Denmark. Denmark is already going down. And in female in Portugal, it's still even going up further. And we see this as well with a lot of other European countries and a lot of countries around the world. So we saw successes, but why can't we bring these successes to other countries or even to other parts of the population in the country? I mean, men and women is a really simple example, but we talked before about social inequalities. Within the country, even if we see then different subgroups of the population, we see this similar trend where then some subgroups are benefited by some prevention or by some other measure of intervention, and other subgroups are lagging behind. And no one should be left behind, right? We're all kind of living in the same country with the same system. So I'll stop that with then the cancer data, and I hope it's useful just to give you an idea how useful it is just to have this simple data. But the fact is that even this most simple data, not every country has it. I was in a meeting 2 weeks ago in the Nordic countries where we are discussing about cancer and cancer data especially. Nordic countries is always the heaven of data for a lot of people in the world. They can link data, etc. But I found out that Sweden, so the cancer registry in Sweden, cannot link the data to mortality. So the incidence, the new cases data cannot be linked to the mortality data. So if we're looking into the data of new cancer cases, we're missing 10% of the population. And then that is just because this whole law about data privacy, that people within their own country can't use and link that data. And in the action guide, it is also said really important how cancer registries or cancer data can help, and linkages could help even further to get in-depth data about information on cancer. Now we're talking about Europe. Europe is the data heaven. There's a lot of data. If we're talking to other countries, and then the data availability is even worse. Only 1 out of 3 countries in the world has any cancer data. If we're talking, I was talking before with some Mexican colleagues in Mexico. So Mexico is a really big country. Only 12% of the whole population is covered by cancer registry or cancer incidence data. So only for 12% of their population, they have any idea about their cancer patients. Out of these 12%, 0% is high quality data. So the data is not even good enough to kind of then get to any conclusion. If we're talking another country that is in All.Can, it's Colombia. Colombia has about 25% of the country covered by cancer registry, so they have quite a good coverage, but only 10% have good quality data. So how do we expect to move forward if we can't see where are we standing today with the cancer, what cancer are important in terms of prevention, but in terms of effective care, or how do we do and implement these guidelines or actions if we don't have data to start with, to see where we are today and to monitor it, to see where we want to go in the future. Are we doing the right thing or not? So data, I hope now, just by showing this and just by bringing the attention to cancer data, it's really simple. It shouldn't be really difficult to collect. You see a lot of countries, even in Africa, manage to collect this data. Mexico shouldn't say, well, it's too complicated to collect. Or Sweden, I cannot link the data because of whatever reason. It should be possible. And then I hope I show as well that it's important for prevention, but it's also important for cancer control in general, and at the end to improve efficiency in cancer control in general. Thank you.
Isabel, thank you very, very much indeed. That's super clear, and actually you're highlighting at least two things. One is obviously the data collection efforts and the fact of ensuring that the data can allow also to measure. That's All.Can's obsession, right? Measure, 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 and clearly the performance of cancer care and cancer care systems cannot be done if we do not have the data. That's part one of the story. The second part of the story is that you're hinting that there are policies or interventions that work. And that's exactly what I think we should be looking at in order to bring them or try and transfer them as much as possible in different geographies, in different jurisdictions. Now, if we move forward and we look also at screening programs, there is Ivana, who represents here today the FPIA oncology platform, which has joined forces with All.Can in order to look at the implementation of the EU recommendation on cancer screening, which is actually an important policy decision and intervention. I believe it's part of the broader Europe's Beating Cancer plan. So it's part of a strategy, in fact. How come, Ivana, would you say that the industry is driving programs and interest and intervention of screening programs? Perhaps there is a connection there to be explained. Thank you.
Thank you, Eduardo. Yes, there is probably something to explain there. So first of all, thank you for inviting me. I am part of Novartis, where I'm in charge of policy for precision medicine, but I'm also the chair of the FP Oncology platform, and here I am today representing all the members of the platform. Just few words maybe so people can orient themselves. The oncology platform is one of the disease platform within the industry association at European level. We got together in 2016, and we have now, it's quite a big platform. We have 20 companies, so all the major companies active in the oncology field are part of the platform, and also the national association. So we do policy work, pure policy work, at European level and then at national level. And all our work is inspired by one vision, which is the one of accelerating time to patient access. So every cancer patient in Europe should have timely access to the cancer care they need. And with this in mind, all the activity we do, they have to converge around this. We engage with different stakeholders or different other organizations in order to push the implementation, for example, in Europe, of the cancer plan or other initiative. And I know this is a European story, so for colleagues of All.Can in the international audience, I hope this is also interesting for you, because we have sister organizations in other parts of the world, so who knows, maybe other collaboration can come there. but also as a platform, we look for best practices from other side of the world that we can look at and see what can be adapted to Europe. So in the context of this work, we had the collaboration with All.Can, and Eduardo, you said, why on hell they want to work on screening? Because yes, let's face the taboo. We are a group of innovators. We are an innovative company working on treatment. So for us, the area of expertise is after the screening part, is diagnosis and treatment. There, I think we have something to bring at the table. However, as also you said, when you are in cancer care, you cannot go with a silo-minded. It's all part of the same story. And if we go back to our vision that every cancer patient in Europe has timely access, we fight inequalities, but inequalities are starting since the very beginning. So they are not just starting at some moment of the disease journey or patient pathways, or you choose the name. So for us, when the screening recommendation came out, we said that's an opportunity. It is an opportunity that Europe has to implement program doing right since the very start. To do it right since the very, very start, it should be with the mission and research. But anyhow, if we start with the wrong fruit in inequalities, and we do not apply the screening guideline consistently across Europe, there we create another inequality. So all our work to fight and solve inequality, it's vanified once again. And the other point was, I hope I addressed your question, but the other point for us was also there is so much that Europe can do, member states need to do. So Europe is doing a lot with the cancer plan and the cancer mission. But then cure, it's not happening in the vacuum of the European institution. Cure is happening in member states. So government at national level, they need to be on the receiving side of these things, do adapt whatever they think should be adapted and implement. So with All.Can, we had this initiative in 4 countries, and we choose them together. We choose Italy and Spain because of the interesting of the regional setting. So having things done at national level, it's not the end of the story. Actually, it's the start, because then we have the regional reality. And then we did Belgium and Romania. And all the countries, they decided to do, the objective was clear, so go for the implementation of the screening recommendation, but every country decided to do what was best for their political situation. For us, the point was really raising, put the topic high in the political agenda, so to get the right investment from government for the implementation of the guideline. There were some haha moments. I will not name the country, but no, relax, no. I will not name the country because, the surprise is bigger. At some moment, we realized with All.Can that thanks to the work we did in one country that, again, I will not name, we were the first one in partnership to bring to the attention of politicians that actually are very active in health and in cancer that, oh la la, we have the screening recommendation. Do you remember that?
You can only mention the first letter and the last.
No, I know, I don't. I will not. That's too much. But also we had, very interesting activity, and I call you in Romania, because you were also driving that work as well. Yeah. And I pass to you, because better than me, you were living and driving the story there, right?
Yeah, maybe just to add to the report we sent actually last year and was finalized this year, that we tried to find some data, to your point, Isabel, about the regional screening programs implemented in Romania with European funding. Of course, no public data available. But I was actually, and I will quote one of the members of the Romanian parliament saying that in one of the regions, only 30% of the target population for the cervical cancer actually responded to the call to be part of the screening program. So you can imagine how actually low are the numbers, because we are speaking about the target population in the specific program, not the entire target population. So this is another call actually to use other tools, to your point, Eduardo, on social sciences, to understand what are the barriers at the community and individual level, including for screening.
Thank you. And you did also all this interesting work in Romanian with the hub, also to share information and create public awareness. Now, we are continuing the work with other countries this year, and one of the other countries is Sweden. So, Eb, I'm passing to you, so I'm passing the work to all of you.
She's doing the moderation. She's stealing my job here. No, but
No.
Thank you. I'm kidding you. EBA, as new country in the program, has also a direct experience with Vision Zero Cancer, right? Yeah. And Vision Zero Cancer is focusing as, I think, as a first step on lung cancer in particular. So what can you tell us about these actions and activities that specifically and very concretely you've been carrying out with regard to lung cancer screening?
Mm-hmm. Yes, Vision Zero Cancer is a multi-stakeholder initiative for research and innovation, where we have the ambition to make sure that different actors meet and collaborate so that we can accelerate the integration of cancer results into clinical practice and policy-related actions then into health systems. So we act as more of a convener and a catalyst for change and driving transformation. And it's a group of stakeholders. Among the founders, we have Roche, for instance, and AstraZeneca, and many more. And we are many also same partners also within All.Can Sweden. And so we're also now merging and aligning these different initiatives. And we got an initial seed funding from the Swedish Innovation Agency to actually develop an innovation ecosystem that could drive change, like a forerunner to what we talk about now, like cancer mission hubs. And we decided to start with lung cancer. Just as we said here, we have to start with initiatives in our local context. And we saw what Sweden is doing fairly well in terms of survival and better quality, improved quality of life in many cancers, but not in lung cancer, as so many other, because too many are diagnosed too late, and then all this arsenal of new possible treatments that we have at our hand won't really make that difference that we need them to make. So we said we need to start with the early detection, both among the never smokers and also in the high-risk population, because as you pointed out, Isabel, in Sweden, we see an increase in the number of females, both because of a history until they hit the age because of smoking, but also among the never smokers. And we've also seen the benefits of women responding early to new effective treatments. So if we look at it from the action guide perspective, we could say that we started with a clear shared goal. So we designed the goal, the vision of eliminating cancer as a cause of death, enabling more to live longer and better. That's the vision. And under that vision, we said 4,200 people are diagnosed yearly with lung cancer in Sweden, and as many, more or less, die. And so we said, okay, by 2030, we should reduce those cancer deaths by half. So what do we have to do? And I think also talking about what you mentioned now with the oncology platform, that the pharmaceutical industry and the medical technology industry are more active also from the prevention and screening, is because you are societal actors and you're taking a holistic approach. Cancer is not a medical challenge, it's a societal challenge. It's a tsunami that we need to deal with in new ways in bringing all the stakeholders together. So when we even created this initiative, we did it with the Lung Cancer Patient Association, with the professional working group, the Swedish Lung Cancer Study Group, uniting all the lung medicine specialists, oncologists, researchers that are driving also the care programs and the guidelines, but also then authorities and stakeholders from the Confederation of the Regional Cancer Centers and others, and of course industry, as I said. And so bringing all them from a pentahelix together has been crucial in driving different initiatives, a shared goal. And then, of course, when it comes to lung cancer, then we said, okay, there are several gaps, knowledge gaps that we have been closing. to enable our National Board of Health and Welfare to actually decide on the implementation of screening program. We all know that when the Nelson trial results came and other trials, we know that we have the medical evidence, but there are other gaps that are missing. And if we don't fill them, our authorities won't feel comfortable and certain to actually drive forward implementation. And one of them is the health economic aspects, so that we close that gap by actually commissioning a survey based on a protocol for a screening program in Sweden developed by the care professionals, this lung cancer study group. The synopsis based on the Nelson trial, but adapted to a Swedish context. So then we would come up with that piece of evidence, and others, and also visualization tools for data linking our registries. But that's maybe, if we have time, I can go into that developments too. But mostly what I would like to share as examples. So one of the contextual factors then, also from our perspective, was also this uncertainty. How do we reach the high risk, the at-risk population? Will they eventually come to a screening program? So that became a bit of a catch-22. Unless we know that, we can't start a pilot. And if we don't start a pilot, we don't have the evidence. And all this back and forth. And we felt a little bit like the medical community and the authorities, they were like lost in translation. So we said, okay, we need to do something new. So one of the things then to accelerate and innovate the decision-making process to shorten these lead times was that we created a market survey. So together with the #1 Swedish opinion institute, Kantar Sifu, conducts a lot of surveys and opinion polls, and then also with a data-driven growth agency that works with our language minorities. We created, in a record time, in less than a week, we had a very, very good questionnaire that would take 9 to 10 minutes to reply online. So the questionnaire was shaped by the professionals knowing how to conduct an opinion poll, of course. How do we frame, and how long can it be, and how should it be structured? Then, of course, from the lung cancer professionals, the patient association, industry players, and the National Screening Council and others, we shaped the right questions, building on what should a program also respond to, so that we could identify the target groups. And eventually we had a first panel of 500 smokers and ex-smokers who responded to this survey. But then we saw that the lack of many of the language minorities, because that was also based through their panels on opinion polls, and then looking into screening and the smoking habits, which selected the typical age range between 50 and 74 years of age that would be eligible for a screening program and so forth. And so from that, we had 500 respondents. And then we said, okay, but what about the 20% of the foreign-born Swedish citizens? And that's where we then, with other social sciences, medias, and tools, engaged with communities so that we could also get data from about another, I think it was from the beginning, some 300 citizens, and then those who could full reply to the whole questionnaire were like 130. So in total, we had a panel of 630 high-risk individuals, smokers and ex-smokers. And the results between both of them were extremely similar. 9 out of 10 would attend a screening program if they were offered the possibility. And 9 out of 10, and then also there was no differences then between the foreign-born and the Swedish-born, and the majority would also prefer to be sort of offered to participate through their GP or other health institutions more than other. So the traditional channels are being referred to. There was also a preference, and especially among women, to combine it with other screening programs and so forth. More women than men were open to undergo screening. There were more fear and stigma among men to find out if they would have something and so forth. So we saw a lot of patterns in this, and it also corresponded well also with the demographics of the 20%. So all the data of this actually has helped design very quickly intervention in 3 implementation studies across Sweden. So one is already up and running, and 2 others are starting in other regions where we're testing different methods, more about getting the referrals right, building it also with AI, the radiology capacities, et cetera, et cetera. But it has, for the authorities, been like we have shortened their lead time. So when they can finally start saying, hey, let's now decide on a screening and the thorough evaluation process, we have cut it at least by a year and a half, thereby saving several hundred lives. And as an impact of this, I can also say that in our first pilot ongoing, like an implementation study ongoing in the region of Stockholm, they decided to link it with the mammography screening program, and now also extending it to men, and they screened 1,000 women. They found 10 women that they have cured. So lung cancer can be cured if we find them early. And I think that is a case that I would be happy to share more details into, and a write-up for the Efficiency Hub.
This is fantastic, Ebba. Thank you. Lots of learnings from what you have described. Lots of things that can be extrapolated now. It's time to participate. Everyone, here's the Mentimeter. Please have fun, connect with Mentimeter. And in the meantime, if there are a couple of questions from participants, please do not. Thank you very much. Yes, please, go ahead. Yeah. Go ahead. In the meantime, all the others will do this. So everyone has got some homework.
Okay, thanks, Eduardo. My question and comment is directly to you, Eva, and thank you for this great explanation. I just want to echo and endorse what you just mentioned regarding cancer control is not, well, it wouldn't be considered as a medical challenge, but as a social and political will and authority challenge. And the thing here is that probably, I mean, the question is, what happened with all the outcomes that you obtain from these surveys, informs, papers that you provide to the authority? Because sometimes in countries like us, like ours, such as Mexico, they just receive the information and that's it, you know? And behind all the great work that probably take us months or years, there are probably solutions to them. So what can we do to push, you know, the actions? We talk about calls to actions, you just mentioned, Eduardo, but what can do the NGOs or what the part of the ecosystem, because all of us here are part of this ecosystem, what we can do as an external effort?
Thank you. The question is to you, 1 minute. And then call to actions, and then we close with the final Mentimeter.
Okay. Very quickly, the key to addressing systemic challenges is to address them together. So the togetherness, make sure that you collaborate, that you become a trusted partner with the authorities. Create living labs with them. So because involve them in the putting together, like we involve them with the questionnaires, everything. So we know this is part of their pieces of evidence to their continued process. And then we know, everybody knows that when have you to step back because they have to have their decision making going as well. But also involving in this, I think, learning from each other, the communities. We have also invited our authorities to learn from UK, for instance. So we pull them together, a lot of international exchange programs, policy networks, and so on, so we can drive initiatives together. For instance, like the lung cancer policy networks and all the activities that we've done globally helps also to inform and create a momentum. And now it's a momentum talking about multi-stakeholder partnership. So that could be leveraged, for instance.
Thank you very much, Ebba. Now, a call to action and quick reactions from all the panelists before we close in order to maintain the efficiency of the program. Marius.
So the call to action is, of course, to use more and more the social sciences and advanced tools. And this is actually a challenge from some perspective. Excellent about what you did in Sweden. And I think we can consider actually many types of tools and methods to be used according to, to the scope of the project, of the intervention of the community, and so on. 60% of the health determinants are actually individual and social determinants. And this is not part of our current conversation about health. On the other side, for the social scientists, it's not so easy to understand us as people coming from the cancer field. And we actually we collect the first data in September last year, and we actually spent like 3 months, and we had a workshop to align with the key opinion leaders in the field of personal and social network analysis in Europe, because these methods are actually known for decades, but were not used in the cancer. So we had to make sure that from a scientific point of view, everything is clear and so on. So I refer to the citizens. And one more mention, because this type of methods can be used in order to better understand the stakeholders. And especially in the pentahelix model, it's crucial to use totally different approaches when it comes to with the stakeholders mapping. And we are using this in the project. We are trying to measure the interactions from coordination, collaboration, financial ties. And my final word, in a traditional way of mapping the stakeholders for cancer primary prevention, you can identify less than 10. In our project, we identified around 130 European, national, regional, and local stakeholders.
Amazing. Thank you, Marius. Isabel, now, what about your call to action and maybe
Am I allowed to have 2 or only 1?
minute?
Oh, no, actions.
Actions,
Two. Okay, so the first one would be, I would like to see that prevention is higher on the top of the priorities in countries. If we see today, I think there's a study measured how much actually countries are spending money on prevention. I think it's 3% that they put then into prevention. It's really little. If you think of health budget, 3% goes into prevention. And now hearing Mario saying, it's not only governments who are not convinced about the role of prevention, even people and community think that prevention is not important. So I would wish that everybody, not only government, because if we, the people, think that prevention is important, I think it would come to the government as well that, okay, prevention is important. If someone could bring that higher up, it would be amazing. And then the second thing is then to kind of bringing up also then the importance of data. It's very simple, but countries can really improve and expand the availability of good quality data to drive action in cancer control.
Amazing. Thank you. Thank you so much, Isabel. Ivana, then your calls to action or call to action as a next step.
Thank you, and I hope I'm not disappointing you. I'm also looking to my fellow EOP member in the room. I'm not going to call for an action. I'm going to call for a behavior, probably. We are innovator. We bring leadership in innovation, but we are also very pragmatic in the way we operate. And we call for accountability. We took a commitment with citizens to fight against what Ebba said. It's a societal issue. It's not just a horrible disease. There is a lot of knowledge in the community. We know, you know, everybody knows here what should be done. Let's do it. Be accountable with the promise you made to citizens. Sorry if I disappointed you.
I'm never disappointed.
It's not an
by
action.
you.
It's
Never.
a call to behavior. Behave.
It is an
It all
action
starts
as well.
with behaving, doesn't it?
Okay.
It's an action to behave. Thank you very much, Ivana. Ebba, final word to you, and then Mentimeter.
Okay, I'll echo what you said, and I'll build on that. I think I was coming back to, we said we're not going to mention this country or that country. I think the more we acknowledge that we have a lot of challenges, the better we can learn from each other and drive change and improvement. So I would say transparency drives improvement. Be prepared to share and to learn. we're in this together. And I think you see that when you start measuring and comparing data, and to use it from learning, then you can really, really improve. And we have so many good cases from the field of cancer as in other diseases by working like that. So I think it's a call to action, also behavior, and I think we as a community could lead that way, definitely, with our action guys and many others, because we are trusting each other, it builds with that. And just finally, I have to say it, but we have actually, with the colleagues of AstraZeneca in Sweden, so special thanks to Elin Ferner, who is also the board of All.Can Sweden, we have developed now, and we launched at an All.Can summer meeting this summer in Sweden, Viscan, which is a visualization tool, and we now got the authorities to bring in all the data so we can have a good comparator, also bringing in the socioeconomic data and others with mortality and other registries. And lung cancer has already come further in that of sharing. So stay tuned for that one as well, that we could perhaps share.
Fantastic. Thank you, Ebba, very much. Please have a look at this final Mentimeter, and then we can adjourn. There you go. I think this is also, if you allow me, a clever way to address certain issues, because sometimes the ranking of countries is seen as a sort of name and shame type of game, which can work if a given authority is competitive in a healthy sense of the term, but it can also be discouraging or putting them away. So instead of naming and shaming countries, we can look at the programs and the nature of programs in order to understand the extent to which they correspond to given countries or to given policies implemented in those respective countries. So here, the winner is investment, efficient investment in screening programs appears to be the first thing that you participants would advise to advance and also promote. And all of this will be kept, of course, and then will be kept for the records of the meeting. It will be shared subsequently so that we have a record of the results of the Mentimeters. We have a record of the calls to action. I can only now thank hugely all the panelists. I will start this time from Ebba, Isabel, Ivana, and Marius. And as they say, I'm standing between you and lunch, so I would like to adjourn this session and thank you all for being here. We'll be back at 1:45 for the third panel. Thank you very much. Big round of applause to our panelists.
Thank you. I'm going to share that.